Welcome to the National Child Traumatic Stress Network Speaker Series, Understanding the Complex Needs of Commercially Sexually Exploited Children. Today you'll be participating in the first webinar in our 6-part series focusing on responding to the complex issues of commercially sexually exploitation of children in child welfare, sponsored by the NCTSN Child Sexual Abuse Collaborative Committee. My name is Jennifer Grady, and I will be moderating today's presentation. In recognition of the importance of a multi-systemic response to the needs of CSEC youth and to promote knowledge and communication within and across the intersecting disciplines within such a system, we've developed this speaker series comprised of webinars, each from the perspective of different field or discipline in a system response to CSEC. We've identified child welfare, juvenile justice, mental health, medical, and victim services as important sectors to include in the series. Our goal is for each of the individual webinars to have a standalone value for participants in their respective fields. That is, we would love to be informative for a person from the child welfare workforce who elects only to participate on that webinar. However, we'd also like to be of value to individuals from other disciplines seeking to have a better perspective of the larger system and the work of other partners. I invite all of you to participate in the entire series to take advantage of the perspectives and expertise provided. Before we begin today's presentation, I need to share with you a few reminders. We're anticipating a large number of participants for today's presentation. If you experience any technical difficulties at any point, you may email us at help@nctsn.org. Those connecting over the web may also switch to the phone at any time by dialing 866-295-5950 with the code 531-8986. The format of this presentation does not allow for you to speak directly to our presenters. However, we encourage you to ask questions at any time. Those viewing this presentation over the web may submit a question at any time by clicking on the blue box that says Questions. Those joining us by phone may submit questions by sending an email to question@nctsn.org. If it involves a technical issue, a response will be sent to the email you provide. If you'd like a copy of the slides for this presentation, they may be downloaded from the Learning Center. We'd like to ask that all of you complete the post-presentation evaluation survey. This information will help us tailor future presentations in this series and in subsequent series to our audience and provide useful feedback to the presenters. Also, anyone wishing to receive CE credit for this presentation may complete the post-presentation evaluation survey first, at which time you'll be prompted to complete a CE post-test. After passing the post-test, you'll be able to print out your CE certificate. We are unable to provide any hard copy certificates via mail. Today's presentation will be archived on the Learning Center website. This makes it possible for you to review this presentation at a later time as well as complete your CE post-test questions and print the CE certificate. I am very excited to present to you the individuals who agreed to present on today's webinar. First, I'd love to tell you about Jen Hostler, who's a master's level social worker at the Chadwick Center for Children and Families at Rady Children's Hospital in San Diego, California. In addition to her work as a child welfare worker, Jen has 8 years of experience working with traumatized children in a variety of settings, including residential treatment, juvenile justice, and foster homes, in addition to 2 years of experience working as a hospital social worker. Throughout her career, Jen has worked with youth who have been trafficked, primarily in residential and juvenile justice settings, but additionally through her work as child welfare investigator, ongoing case manager, and emergency room social worker. Our next presenter is Charisma de los Reyes. She's an MSW and a senior protective services worker and human trafficking commercial sexual exploitation of children liaison for child welfare services in San Diego County, California. She has 13 years of experience in social services and is recognized as San Diego's Child Welfare Agency's Human Trafficking and CSEC subject matter expert, providing training, policy advisement, consultation, and technical assistance to social workers and community partners across the country who encounter victims of human trafficking or children at risk for commercial sexual exploitation. Our next presenter is Jen Etu. She's a licensed independent clinical social worker in Rhode Island and holds an MSW at the Family Service of Rhode Island's Clinical Administrator of Trauma, Loss, and Children's Services. She supervises and administers the agency's residential treatment, foster care, and family coaching and visitation operations. She also provides oversight of implementation of trauma symptoms therapy, My Life, My Choice, and Think Trauma programs. Finally, she acts as a liaison between Family Service of Rhode Island and the community and community service providers, including child welfare, in order to promote and ensure access to services. And our last presenter is Mike Correa, who is a detective captain in the Providence, Rhode Island Police Department. He supervises the Detective Bureau. As the detective commander, Captain Correa directly supervises all homicide investigations, shooting investigations, robbery, sexual assaults, human trafficking cases, and all other serious incidents. He has firsthand experience with sexual assaults and human trafficking investigations. Throughout his direct involvement with these sensitive investigations, Mike has learned that compassion and genuine concern for the victim's well-being ensures a trusting relationship with the victim, leading to successful outcomes. I am very excited to hand over today's presentation to Jen Hostler.
Thanks, Jen. Good morning, everyone, and good afternoon for those of you on the East Coast. As Jennifer Grady mentioned, my name is Jennifer Hostler. You'll see on our panel today we have a few Jens on this team today, but I work at the Chadwick Center for Children and Families at Rady Children's Hospital in San Diego, which is a child advocacy center with a variety of programs around the county with the mission of promoting the health and well-being of abused and traumatized children and their families. My personal background is in child welfare, where I have worked in both Minnesota and California as a child welfare worker. However, in my current role, I serve as a child welfare systems change specialist as part of a 4-year project funded by the Substance Abuse and Mental Health Services Administration as a Category 2 center of the National Child Traumatic Stress Network. Our center really began to focus some of our work in the child welfare system about a decade ago, and our current project, which is the Chadwick Trauma-Informed Systems Dissemination and Implementation Project, which is quite a mouthful, we also call it CTISP-DI, is the result of partnerships with the NCTSN and SAMHSA for the past 13 plus years. My current role focuses on creating trauma-informed child welfare systems within 5 child welfare jurisdictions that are part of our project from around the country. And we also work with the child welfare partners in the communities that we are working with. Due to my background in child welfare, our involvement as a center with several child welfare committees within the NCTSN, as well as our work within the child welfare system over the last decade, I was asked to assist in the development of this webinar by finding experts that have worked with this very vulnerable population of children. We know that this population of children is especially vulnerable in the child welfare sector due to a variety of reasons, including a history of abuse, neglect, and other traumas, in addition to placement issues for children who have been placed out of the home, their complex needs, in addition to complicated legal issues that often impact these children. We also know that in order to address the complex needs of these youth, we must develop new ways of engaging and treating them. Across the country, child welfare is undergoing a fundamental shift, which is moving away from the old way of diagnosing, medicating, and blaming the victim to creating more safe and permanent spaces for youth that are survivors of trauma. This is especially critical with trafficking survivors as we move away from treating these youth as criminals and move towards a more victim advocacy model. This particular topic is also very relevant to child welfare due to the prevalence of youth in child welfare that this issue impacts, with numbers reported between 50 and 90% of CSEC victims having a history of child welfare involvement. As I began my search for these experts, I was led to our 3 panelists today, which we've come to call the Dream Team. I think you'll see after hearing them all speak why that's the case. But after reaching out to my local child welfare community here in San Diego, I was consistently told that Charisma is really the go-to for all things CSEC in San Diego County. She's made a name for herself both locally and nationally, and has a wealth of experience working with this population of youth, in addition to experience developing an entire protocol to serve these youth in our emergency shelter. I was also led to our panelists from Rhode Island, Jen Itu and Captain Correa. Rhode Island is one of the communities in our project here at the Chadwick Center, so I was already very familiar and aware of some of the excellent collaborative work happening there, and connecting with our child welfare partners in Rhode Island. Jen Itu and Captain Correa were consistently mentioned as passionate and well-versed in the complex issues affecting CSEC youth across the state of Rhode Island. You'll hear by example today from them how much of a difference this unique collaboration has really made to identify and treat survivors of CSEC, in addition to efforts being made to change the culture within their organizations. Lastly, I just want to mention that each person on this panel today is involved with NCTSN activities focused on improving the systemic response to working with CSEC survivors. And we look forward to hearing from our cross-system partners and other systems, including juvenile justice, mental health, medical and victim services in future webinars. We're very excited today to be here to kick off this speaker series, and I just want to thank Jen Grady from the NCTSN for having us, in addition to Kelly Knish, who's another NCTSN partner who's helped facilitate and pull this together. So without further ado, I'm going to hand this over to our panel, and Charisma, I'm going to let you take it from here.
Thank you, Jennifer. Good morning, everybody. And Jen, thank you so much for that wonderful introduction. I do have to recognize that while I didn't do the protocol on my own, I was a part of an amazing, incredible team within my Child Welfare Services department here. And so a lot of work went into that, and I think we are about to publish our county plan. And I'll get more into that as we move on. So a little bit about the Polinsky Children's Center. It's a 24/7 facility for temporary emergency shelter. We serve approximately over 300 children each month as they are admitted for issues of abuse and neglect, and we are licensed at a capacity of 204 children. On campus, we have 6 residential cottages, a nursery, on-site school, library, infirmary, and gymnasium, and along with incredible staff who are very committed to really doing what's best for the kids here in their short stay here. And so while I've been with the agency over 10 years now, but have been a practicing social worker for a little longer than that, I was strategically placed here at the Polinsky Children's Center to work with CSEC-involved youth and also to develop a prevention and early intervention program to engage children at risk for CSEC. And so if I can just take us back a little bit, I think, are we on to the next slide? I apologize.
Hey, Charisma, you're going to talk about the CWS CSEC protocol?
Yes, thank you. And so the CWS CSEC protocol was established through Senate Bill 855. And so what California was able to do, and it passed in June 2004, it gave jurisdiction to child welfare to help protect CSEC-involved youth or those at risk under our Welfare and Institution Code 300B2. The Senate bill also gave counties the ability to opt in to develop a CSEC program. And so 8 counties opted into this program. And quickly, the CSEC State Action Team under CDSS, the California Department of Social Services, designed a model interagency protocol framework, which was designed to incorporate the legal requirements of the CSEC program as set forth in the statute, including the required participants and the mandatory multidisciplinary team approach. It further provides guidance on promising practices based on research. And so as an example, as a part of our county plans, there are participants that are required, which includes child welfare, probation, mental health, public health, juvenile court, and substance abuse. We also have a steering committee made up of several partners, and the multidisciplinary approach is really what is critical in combating and addressing this issue, not only here, but really anywhere. And then through this program, we established a CSEC liaison program because we are divided up into different regions. And so workers could go to that CSEC liaison and provide technical guidance and consultation, but also participate on the steering committee so it keeps us all moving forward. And so as a part of me being a point of contact at Polinsky, bringing trauma, or not bringing, but enhancing the trauma-informed practices here was also instrumental in identifying and being able to identify youth who were brought in to our emergency shelter. And I'll talk a little bit more about that. So the goal really is to be comprehensive, collaborative, and coordinated. Because oftentimes, as many of you know, working in large government agencies, sometimes there can be a disconnect in communication. And so the goal really is to be comprehensive, collaborating, and coordinated so that children don't fall through our cracks. And so when we look at the issue of safety in an emergency shelter, we're always assessing for safety and risk. And within our protocol, or within the CSEC program, we designed a protocol that looked at identification, case management services, partnering, and other issues, and of course delivery of service. And eventually, not eventually, but really with the goal to prevent any more youth to being ensnared in this crime. And so at Polinsky, when children are brought in, immediately they are screened. And we have 3 categories when children enter. We are looking at-risk children, those who are suspected and confirmed or known for CSEC. And so how we identify those at risk, there are certain red flags or indicators, such as AWOLing, substance abuse, age, even number of placements, that, if the child has a number of these, but there hasn't been any other evidence to show that they have been involved in CSEC before, we will categorize them as at risk so that we can do an assessment, a more solid assessment. And so safety, in terms of safety as well, there's always the worry of recruitment, and which is a very sensitive issue, because as we don't want to label or accuse other youth of recruiting, we know that based upon the patterns of behavior and things that have happened in the county, that there certainly is recruitment, whether it's befriending, seduction, or even force and coercion. And so what we're noticing here in San Diego with the recruitment issue is really not even specifically recruiting into CSEC, but through the enticement of AWOLing or running away, where youth run away from a placement or from their homes or schools or communities, and they think that they're just going to go out to party for a weekend and then come back. However, the person who was recruiting them had already designed the plan. But they said, no, we're just going to run away and AWOL and have a good time over the weekend, and then that's it. But the victim has no idea that the plan was already put into place, and now they are involved in commercial sexual exploitation. And so how we work on that and prevent it here at the Polinsky Children's Center is constant safety planning, constant. And we have real talks with our kids, usually between the ages of 10 to 18, and of course it's all age appropriate. And we talk about what is the risk of running away from anywhere, right? From whether it's a placement or their home. And that CSEC really is just one of many risks that are out there. And so they know that they can always return to Polinsky if they find themselves in trouble as a safe haven. And so we want them to know that, and we understand that, unfortunately, running away behavior is certainly recognized as a maladaptive coping mechanism. And so how do we treat that symptom of trauma? And we're constantly building safety networks, especially if there are issues possibly with the family of origin, and so really to broaden and enhance their existing networks of safe people. So it's not just including, providers, teachers, but, it could be faith-based folks. It could be the next-door neighbor. I mean, these natural support systems. And so we would like to really encourage that and strengthen that and wrap around that child. And so I know right now one of the big issues is screening tools. And so in our CSEC program in San Diego, we have opted to use the West Coast Clinic CSEC screening and assessment tool. And I believe there should be a link to that. And so the West Coast Children's Clinic, their tool is called the Commercial Sexual Exploitation Identify Tool, CSEIT, and it looks at 10 different domains or 10 different areas, such as stability and residential status in life, physical health, risk behaviors, trauma signs and symptoms, coercion and grooming, and exploitation, to name a few. And so there's a summary or a total scoring on this screening, and based on that scoring, there are either no concerns, possible concerns, or clear concerns of a youth being at risk for CSEC. And so this is going to help, and what is good about this tool, it can be used by a universal screener. So it doesn't require any special licensure or anything like that, but of course we will receive in-depth training on how to properly use this tool to, of course, establish standards and appropriate referrals to services. And so I just wanted to also share, in addition to their screening tool and assessment, they also developed a matrix of different screening and assessment tools, and I believe there should be a link to that as well. And they looked at several different states on what were promising practices in the field at this time. And so if you are looking for a tool, I think this would be a great help for you to see, because it looks at the organization, the tool name, the validation of the tool, length, source of information, etc. And so while I think the nation is looking at child welfare kind of as the go-to to handle such issues as CSEC, especially now that it's coming under our jurisdiction, we will always have the practice of family engagement throughout our entire intervention, whether it's at the investigative stages, whether we're providing case management services, and of course eventually the closing of the case. But throughout that entire life of a case, we are constantly practicing family engagement and looking at safety and risk, because we believe in San Diego that really home, if we can safely return home, and home can mean a number of things: family of origin, community of origin, school of origin, that we are constantly enhancing and strengthening those safety networks, as I have mentioned before. And so we use the safety organized practice, which is our practice framework designed for standardizing our practices here in the field, really working towards better outcomes for children and youth involved in the child welfare system. And in addition to that practice, we use existing models for collective ownership of what happens in a child's life, what happens in a family's life, and really extending into the community. So we use such meetings as the child-family team meetings, team decision-making meetings, where we bring lots of folks, the right folks, to the table to discuss, what is working well, what is it that we're worried about, and essentially designing a plan of action. And these aren't one-time type of meetings. I mean, it's constantly held throughout the life of the case, kind of depending on what the need is at that time. And so, of course, there's always resiliency building, where, yes, this traumatic incident has happened, but not only focusing on what has happened, but the post-traumatic growth that can happen from that incident. And of course, the resiliency building isn't only for our youth and our families, but also recognizing secondary traumatic stress for staff as, we continue to do the good work day in and day out. And so some prevention and intervention strategies that we have implemented here on campus at the Pulaski Children's Center is that we team together with our on-site mental health providers, Fred Finch, which is a county contract. And so each child is assigned a therapist or a developmental specialist, depending again on their age, to do an assessment, a comprehensive assessment, and make recommendations and set up a service plan, which will then follow the child into their permanent placement once they transition here from Polinsky. Specifically around CSEC, we work very closely with our mental health providers for their group session programming. So some of the programs that we're using is My Life, My Choice, Word on the Street, that comes out of Los Angeles County through an amazing probation officer, Michelle Guyman, and then, of course, the GEMS, Rachel Lloyd's amazing team out in New York. And we engaged the youth through using her last book that was published, The Survivor's Guide to Leaving. And when working with youth here, we are constantly talking about prevention. What does grooming look like? You may be getting groomed to become involved in something really dangerous, and this is what it may sound like, this is what they might be saying. And so whether or not the children acknowledge that, this is happening or that they're involved in it, they now know that someone else knows what is happening. And I think that's one of the biggest things for kids to come out of their shell, or to make them feel safe enough for any type of disclosure, or even just to ask questions, is creating that environment of safety, right? We're saying, we do know about this, we know this is not your fault, and we know how this happened, and we're here to help, support you in any way. And so we don't do this in a vacuum. Here at Polinsky, we make referrals to community-based organizations that we partner with to provide services and, of course, linkage to resources, so that, again, there's that warm handoff from the Polinsky Children's Center into their permanent placement to avoid the falling through the cracks. So I just want to identify some programs here in San Diego: STARS program, Project Life, Generate Hope, Bilateral Safety Corridor Coalition, and several others that have been working tirelessly on this issue to partner with child welfare, law enforcement, probation, and all of us who are involved in combating this issue. And so finally, there is certainly a consensus in San Diego that regardless of what door or gateway a child comes through, that we are all gateways to safety, that we are all screening and ruling out for different risky behaviors, and in particular for CSEC, and that we can identify early through screening and assessment, develop a service plan where we are all working together with a victim-centered approach and the child's best interest, and then, of course, linkage to trauma-specific resources in the community, because those certainly will become a part of the safety network out in the community, especially if the agency has already exited or closed the case. And so the three things of comprehensive collaboration and coordination, of even resources and even knowledge and learning, the things that we have learned from working together. I mean, our work team has been working on this issue since 2009, and we certainly have learned a lot and have grown a lot. And I know Mike later will talk more about the importance of collaboration and teaming with law enforcement. But really what it comes down to is the empowerment of youth and families and communities. That once, having learned about the tools, learning coping skills, it can certainly lead to universal prevention to address this issue, not only locally, but internationally. So I am going to pass the mic. I'll hand it over to my esteemed colleague, Jennifer Itu.
Thank you, Karisma. This is Jen. Good afternoon, everybody. I am the Clinical Administrator of Trauma Loss and Children's Services at Family Service of Rhode Island in Rhode Island. My work directly addresses a lot of trauma-informed care within the state, but also within our agency at Family Service of Rhode Island. So just to give a little foundation of the work that both I do in my role, but also the work that our agency does. I am in charge of supervising the clinical services in 5 residential programs and a treatment foster care program. But I'd like to touch upon some macro elements of the treatment work that we do at our Family Services Rhode Island agency. So initially, the starting point of a lot of our victim services work began in about 2004 under the leadership of Dr. Susan Ersling. She's the vice president of our Trauma and Children's Services Department, which encompasses a number of grant-funded and sort of individually funded programs throughout the state, but also through our agency. In 2004, in coordination with the Providence Police Department, we created a collaborative relationship to provide in-person response as a twofold positions. One is a police liaison who provided a service at the agency and also within the police department to respond throughout shifts with police to any event that was as a result of some exposure to child violence. So whether it be domestic violence, homicide scene, a drug bust, or a drug raid, we had a collaborative effort that really involved having a police liaison be with police officers while they did the day-to-day shift. And in addition to that, had a 24-hour response team that still currently functions within the Providence Police Department. We've had a number of other collaborations that have sort of grown from that 2004 collaboration with the Providence Police Department that includes work with our Auburn Protection Center at the Hasbro Children's Hospital, work with both East Providence Police and our Rhode Island State Police, providing additional in-person response teams to any victimization that may occur within the setting of Rhode Island. We've had a number of grant-funded programs through the Office of Juvenile Justice, SAMHSA, and current NCTSN grant-funded work. We've provided a tremendous amount of support as far as training and in-person response to a number of other agencies within the state that include our Rhode Island Department of Children, Youth, and Families, as well as our Rhode Island Training School, which is our juvenile corrections. Our collaborative work throughout the state has really continued to blossom more and more, which includes adoption competence services and services throughout both child welfare, juvenile justice, and sort of community-based work throughout our history at the agency. I think an important common thread, and Charisma really spoke about this tremendously, and something that I think is just a theme that we need to remember throughout this presentation and throughout our work with the CSEC population, is that not any of us can do this job alone. It has to be a collaborative effort in order to get you safely out of being trafficked. It has to be a joint effort between local, state, and federal agencies and first responders. And as we transition to Mike Correa from the Providence Police, he'll be able to talk a little bit more about that. There has to be an involvement with local hospitals and medical providers to ensure that those basic hospital needs or those basic sort of physical well-being needs are addressed right at the initial response and the initial contact with CSEC youth and adults. There has to be a collaboration with child welfare agencies to ensure that the child welfare needs are being met within the family and the individual child context. The ongoing coordination with our child advocacy centers throughout the state of Rhode Island and states throughout the country is also an essential role, whether it be to just ensure that there's a provision of service to both the family and the child, or coordination with court or legal officials. And finally, the most crucial point is obviously that coordination between the family and the client themselves, and to ensure that we're coming from a very family and client competent perspective and identifying what the needs, what the barriers, what the strengths are within the family before we move forward with any treatment needs. Sorry, I'm just transitioning to the next slide. So just to kind of review our child welfare specific programs as it relates to my role at Family Service of Rhode Island, I supervise a treatment foster care program which serves all ages of both male and female clients that have been removed from their home for child welfare reasons, whether it's abuse, neglect, trauma, etc. And in addition to that, I supervise the 5 residential programs within our agency. And there's a continuum of care between those 5 residential programs. We have a short-term assessment and stabilization program, 2 higher-end staff secure programs, a step-down program, and a semi-independent living program serving girls ages 12 to 21. All of those youth are child welfare involved, so they have some element of either child welfare work or juvenile justice work as it relates to probation. All of the youth that we receive in our programs are referred from the Department of Children, Youth, and Family or from juvenile probation through 2 networks of care that we have in the state of Rhode Island. Our treatment programs address the following as far as youth and family needs: exposure to trauma, exposure to sex trafficking, wayward or disobedient behaviors, drug court needs, and juvenile probation needs. Within the treatment models that we use in our residential programs, which will be the majority of my focus for the rest of this webinar, is our trauma systems therapy model. Trauma systems therapy is a comprehensive model for treating traumatic stress in children and adolescents by improving the child's capacity to regulate emotion and behaviors and build promotive capacity among significant others in the community system that the child lives in. Again, to reiterate the point that this is a comprehensive approach when we're working with CSEC youth. We cannot just address the youth needs as it relates to their child or adolescent victimization. This has to be a systems approach to address not only the child and the family, but also the community details that may surround the family. I think Charisma put it really well that we're constantly trying to build natural support so that we can get youth back into the community that will keep them as safe as possible. And in order to do that, we have to have a collaborative effort to build those natural supports. Trauma systems therapy is also a phase-based approach targeting safety, emotion regulation, and beyond trauma in regards to sort of promoting the youth to move forward from the trauma event that they've experienced, whether it's sort of CSEC involved or a trauma history of neglect or abuse. It requires ongoing assessment tools that I'll look at in just a couple of slides. And it's very important to note that we have a very strong collaborative effort with New York Langone at New York University that involves a very strong team of supportive staff, including Glenn Sachs. The treatment model of TST includes detailed trauma treatment and engagement tasks that have targeted interventions to address the needs of child and the child system. Again, kind of going back to that systems approach within family, school, legal, community aspects of the child and family needs. So to focus a little bit more on sort of safety and assessment portion of things on the end of Family Service of Rhode Island, we do have a multi-step assessment of trauma events and trauma symptoms and tools to evaluate that. Charisma has built a really incredible program with her team about how to, protocol about how to assess and evaluate the youth who come in as far as safety and also as far as sort of treatment needs. And we do have a detailed process as well. Within the trauma systems therapy, we have utilized tools both from trauma systems therapy within the model, but also we've created some forms and a safety assessments that really help guide both our staff and our children and families through the process of identifying trauma symptoms, trauma history, coping skills, and symptomology as we move forward in treatment. And because we do have 5 programs within our continuum of care at our agency for our residential programs, it's important to note that some of that safety and assessment process looks a little different because the programs are either shorter term or longer term. And so the way we implement that in our different programs looks different from one to another. So ideally, we use a child symptom stress disorder tool, which is called the CSEC, which comes from trauma systems therapy. We use a trauma safety plan that also includes some staff guidance of do's and don'ts about how to interact with a child who may be having some trauma symptoms or trauma-reactive behavior. And then we do also have a trauma systems therapy clinical assessment that it continues to evaluate any clinical needs that may arise as a result of the trauma exposure or the use history. So on the next slide, one of the highlighted areas that is really important for us to focus when we are assessing and evaluating the needs of the youth is called an individualized trauma safety plan. And as you can see, and it's a little bit smushed, so there's a lot of content there, we evaluate our youth in a in a lot of following areas. So we identify any events that they may have experienced or witnessed that involve some sort of traumatic event. And as it relates to CSEC specifically, oftentimes youth are asked whether they've been trafficked or whether they've been pimped out, and oftentimes youth have a really difficult time engaging around that question because it sort of feels either, one, that they're a victim, or two, lots of sort of other details around their universe as it pertains to their self-worth and how people see them. So we oftentimes change the question about how we ask youth about their trafficking history by just asking them simply if they've ever had to engage in sex or a sex act to get food, clothing, shelter, or drugs. As Charisma reported, a lot of youth often get involved in trafficking after they have gone AWOL, and when they go AWOL, they're often preyed upon by a lot of people who are trying to either pimp them out or pull them into the trafficking universe because they're fallen prey upon because there are basic needs that they have unmet while they're out AWOL. They don't have a place to stay, they don't have food, and oftentimes they're pressured into a place of having to exchange sex or some kind of sex act to get those basic needs met, and that then leads down further to a path of them being further involved in trafficking. The rest of this questionnaire sort of goes as follows. We're asking the youth whether they feel safe enough to be able to communicate to us that there's something going on that we need to evaluate their safety, what situations it may be difficult for them to identify risks, trauma reminders and trauma triggers, also warning signs that the youth may exhibit when they're struggling with being re-triggered, as well as ways to maintain their safety. If we transition to the next slide, this is the assessment tool that we use for our trauma systems therapy model called the Child Stress Disorder Checklist, or the CSDC. This further evaluates youth involvement in trauma events, and specifically there's a question in the second portion that asks about sexual exploitation. And generally during our assessment process, we're again sort of saying, have you ever had to exchange sex or a sex act to get food, safety, shelter, clothing, etc., those basic needs details. So in addition to sort of safety assessment and planning, we are also always focusing on prevention and intervention. Our trauma systems therapy model is definitely both preventative and interventive. So we have some youth who come in with sort of much milder trauma symptoms, and maybe we're doing some intervention work that is really focused on some short-term safety and stabilization, where some of our youth may not have had exposure yet, so we're focusing a lot on prevention. Just to highlight a couple of areas that we focus on that prevention portion is we do have a collaborative effort with the Auburn Protection Center at Hasbro Children's Hospital with their child life specialist, Meg Fitzgerald. Meg is trained in the My Life, My Choice model, which is preventing sexual exploitation among adolescent girls, which Charisma also highlighted. Currently, we're doing their prevention curriculum within our programs, and it's a collaborative effort with the child life specialist from Hasbro Hospital and our clinical team. It's a 10-week prevention curriculum that works on identifying a lot of self-esteem and self-worth areas as it relates to the youth specifically, but more specifically as it relates to their risk or potential for risk of being involved in CSEC. So it's a really great way for girls to get information from a multidisciplinary team of somebody who's involved at the Auburn Protection Center, but also a clinical staff to evaluate risks that may come up for the youth that may have some of those pre-existing trauma symptoms that impact sort of self-worth and the perception of the universe for that youth, and how that may or may not present as a risk for potential exploitation in the future. So kind of a continuum of care and focus on our youth and our families. Within Family Services Rhode Island residential programs, we've created this really exciting continuum of care that involves not only our residential programs, but also a joint treatment team with our community-based services at the agency. And this kind of is an offshoot of that collaborative effort that both Charisma and I have mentioned throughout our slides. We have a joint team that is composed of our community-based case management and clinical staff, both within our residential treatment team and our community-based team. So ideally, the residential team is focusing on the child struggles and the child's treatment needs, while the community-based team is identifying any risks that may be present within the family setting. So a family is assigned a community-based team at the time of intake in our residential programs. The joint team has meetings both in the community with the family, client, and any collateral, so that may involve MDT members through day one, which is our CBC in the state. It may involve police. It may involve DCYF or probation workers. It definitely involves family and any collaterals that may be surrounding the family to, again, build on those natural supports so when the youth does return to the community, they have the support that they need to remain there and remain there safe. The providers that are assigned to the child and the family through the duration of the residential placement are the same throughout this point of intake through discharge and continues within the family setting of the community-based team. At the discharge, the community-based team becomes that full team, as I just mentioned, and ideally the plan here is to decrease interruption of services and maintain treatment model fidelity and provider throughout the term of the child stay within our residential programs. So just for an overview and a wrap-up of my end of the presentation, is our work at Family Services really focused a lot on trauma-informed care, and as it, in particular to this webinar today, CSEC involved youth. We provide a lot of services right from the point of entry, whether it's sort of police intervention or hospital intervention through the duration of care, and a number of programs that we have. As it pertains to my role in residential programs, my specific role is to really implement evidence-based practice that is trauma-informed for youth that are involved in CSEC and have trauma symptoms as a result of their previous exposure. I'd just like to remind everybody as I wrap up that it's just really important not to judge each day by the harvest you reap, but by the seeds that you plant. I often tell my staff when it relates to self-care or working with our youth that oftentimes present with very challenging trauma-reactive behaviors that we are not always going to see the outcome of what we do right then and there, or not even a month into their service. But hopefully 3 to 6 months after, we're going to provide a service and a level of care for our families that they'll be able to really move forward in a way that the trauma-reactive behaviors are less present and they have a much more pro-social interaction with whoever they interface with. I'm now going to wrap up on my end and pass the baton over to Detective Captain Michael Correa from the Providence Police Department. And thank you.
Good morning or good afternoon. Thanks, Jen. Again, my name is Mike Correa. I'm a detective captain in the Providence Police Department. And I'll briefly like to talk about, if I can get myself reoriented here, I apologize. Again, I've been a policeman for 28 years. I've seen a lot of changes in those 28 years, both institutionally within the police department and also personally. My first slide speaks specifically to trafficking of children. It could broadly speak to trafficking. Mentions current trends. I think the good news is the current trend is law enforcement is up to speed, fully recognizing human trafficking for what it is, a real serious issue. A real serious issue that involves both adults and children. And that's a good thing, because it hasn't always been that way. In the very beginning of most trafficking thoughts involved around prostitution laws, which is, that's the wrong way to go about it, clearly. It isn't a vice issue, it's a victim issue. But it's taken a while to get that way. Most times, prior to really getting a lot of training, this was looked at as there would be a prostitute and there'd be a pimp, and that relationship was pretty much a mutual partnership, if you will. Most young people, either victim, male or female, weren't looked at as victims. So that's the good news. The current trend is that law enforcement certainly recognizes human trafficking for what it is. It's certainly a victim. It's a crime that has some serious consequences for the victims. And that change has really taken place due to training. There's tremendous training out there, and police departments are taking full advantage of the training, and that's a good thing. I know on the first slide it mentions a partnership with family services. Jenny, too, mentioned that. I have it as just a bullet point. It's much more than a bullet point. 2004, like Jen mentioned, Family Services of Rhode Island partnered with the Providence Police police department was something very new to us, something that we weren't used to. We were bringing people from outside law enforcement into our police department. They would ride with us every day. And the idea was that we would attempt initially to try to break that cycle of violence, that learned behavior of violence in the home that children are exposed to. And so we would have a trained professional with us that would really interject services from the get-go to the victim, to these young children that were witnessing violence. So that was the intended consequence. And it was a very maybe unexpected, unintended consequence, is that family services had this it really transformed the police department culturally. We started to understand the needs of victims. We started to recognize victims. And once we started to do that, boy, I think we really became, a really more efficient, a better police department. Clearly, never intended that to happen, and it really was an unintended consequence and a really good one. So it's much more than just a bullet on a slide. It is a real meaningful relationship, and I think that's important. If the one thing that you do take away, the clinicians and the child welfare advocates that are participating in this webinar, if the one thing you do take away is that you really do make a big difference in a police department. You can change the culture of the police department. I can say that without any reservation because I've witnessed it firsthand. So I think that's an important takeaway. The other thing too is that the slide mentions that the pressure from advocacy groups, helped us refocus our efforts. And that's true. The laws changed. All of the attention that has been brought upon trafficking and the victims' end of this has been spearheaded by advocacy groups, and to me you can't lose sight of that, of how much influence you have. I don't want to bore you with details, but I will tell you a little bit of a story. Policemen tend to like to tell stories. This is a story I think that illustrates this change in culture. So in my early part of my career, I was a narcotics detective. We would go into a house, and if we couldn't get in there, we would crash the door down, and we'd be looking for drugs and money and guns, and if we got drugs, money, gun, and we had somebody in handcuffs, out the door we would go, and many times we'd be high-fiving each other, and there would be kids in the background probably devastated, traumatized by what they just saw. And I don't say this proudly, it's just the truth. And we didn't know any better. And then we would just leave, and it was considered successful. Nowadays, thanks to the influence of family services of Rhode Island, if we have any idea that there's kids inside of a house, we bring family services with us. And once the scene's secure, we interject services right to those young people who might have witnessed, us coming through the door. And I think it just truly illustrates, what an influence family services has been on the Providence Police Department. So we'll move over to the next slide. So part of the problem with law enforcement is we had to redefine what success is. And also redefine kind of, what we thought about this crime. And a lot of times there was a bunch of myths that had to be overcome. And I'm happy to say that we've overcome these myths. Some of them kind of went along this way, where victims knew what they were getting into. They can't be doing it against their will. They're free to leave, that type of thing. So we've really moved past those types of myths. And a lot of this is because of the advocates, because of the partnerships. So we've become, I think the old way of doing business is clearly, like the slide says, we're focused on offenders. The old story of success was, an arrest, a prosecution, a conviction. That was success. And we really are in the process of redefining what success is involving trafficking of children. And it has been more victim-focused, clearly more victim-focused. Part of the real. That's a real thing. My experience. I think in the beginning, you would think it was happenstance or luck that these pimps would come into contact with the victims. It's clearly not. My experience has told me exactly what charisma says, that there's a grooming process, there's a recruiting process. And that's been part of the evolution of law enforcement dealing with this. Move over to the next slide. And again, this victim-centered approach of law enforcement clearly is directed, again, from that family services our contact with family services really helped us. And I think now in any of the cases we do now, really it's the victim-centric, victim first. That's the most important thing, is the victim, the safety of the victim. So as a supervisor now, I've kind of had to kind of prepare my bosses, if you will, that I call it swings and misses, and meaning that there's gonna be a lot of effort sometimes, and maybe that effort won't result in an arrest, won't result in a prosecution, and won't result in a press release. But it may result in just you're getting someone out of harm's way, you're getting a victim out of harm's way, and we're there now. I think most progressive law enforcement people, supervisors, all the way down to the rank and file, recognize that a rescue mission, if you will, is a success. So we're moving in that good direction. We'll go over to the next slide. And the funny thing happened is so now we're more victim centric, and in an effort to be more victim centric and be all our concerns to the victim, you need to develop trust, and that trust is kind of funny, had an unintended consequence in that it helps us down the road. And I'll get a little ahead of myself, but I think we've recognized the training has told us that these victims are embarrassed, vulnerable. I mean, think about how terrible it has to be to tell somebody that you've had sex for money or sex to put food on your table, like Jen said, sex to feed yourself. Clearly, very, very embarrassing issue, and that's not an easy story to tell. One of the things I did learn is that we kind of assumed who the victim would trust. We just assumed it would be a female. And in a case I'll discuss a little bit, but not too in depth, it ended up being a 55-year-old kind of grouchy detective sergeant who this female victim really latched on to. One of the things I try to always impart anytime I get a chance to talk to people, and more law enforcement, is that this trust, you develop it from the very beginning. And I use this phrase, no handcuffs needed. Many times the way we ensure someone's safety, a victim's safety, is they're actually under arrest, in the sense that they're not free to go, but we don't arrest them in the sense that they put handcuffs on it. That I think it's symbolic in a sense. I mean, a little hard to put someone in handcuffs, and then maybe an hour later you say, we really want to help you. I don't think you can sell it after that. And that's kind of, that's a developed, we've learned that. That's a learned trait. We learned it firsthand in the very first successful case that we made. There was kind of progression in I'll just quickly give you a brief history in the state of Rhode Island. We had been doing some of these cases with Asian massage parlors, 2001, 2, 3, and 4, and then all of a sudden a loophole developed in the law. For a brief period of time, or maybe not all that brief, we had actually had legalized indoor prostitution in the state of Rhode Island. 2007, they threw the push it through advocates, and we have a new law, and the law is one of the best. And really, really tough law when it comes to human trafficking of minors. Expands the definition. It doesn't even have to always be sex for money. It could be as simple as working in a strip joint, for the lack of a better word. I refuse to call them a gentleman's club. 2007, we get a new law, and then we're getting some training, and then we get our first we get our first complaint in 2010. We get a complaint. It really seems to be a big issue. It's a serious issue, and we develop a plan. I'll move over to the next slide, and we develop a two-stage plan, basically, which is we really just want to help the victim, locate the victim, get the victim, arrest the victim, if you will. Like again, not free to go, but certainly not in handcuffs. And we don't put this young girl in handcuffs. We right from the beginning, we explain to her. We know she's a victim. We understand that. We really work on getting her into safety, out of harm's way. The plan B was we had always hoped all along that we would, gain her trust and she would want to participate and cooperate in the criminal justice system to really, put the people who did this, to hold them accountable. And in the end, it worked. When we first brought this young girl to the police station, and again, brought her in right from the beginning. We know she's a victim. There was no pressure. There was never any pressure on her to give us a witness statement, tell us what happened to her. We explained to her that her uncle was on the way up, and he was going to get her and bring her home. And she was emotional. And I think our approach really convinced her. I think she recognized that we really cared about her. And I think in the end, that's why she came back. In a month's time, she came back. And then she went through the process, testified at grand jury. And by 2011, we had the first conviction in the state of Rhode Island of human trafficking, and it really started to open some eyes and move forward. And we never would have developed this approach, this victim-centric approach, unless it was for advocates, unless it was for the partnership with family services. We move to the next slide. This is where kind of off law enforcement, now we're understanding that you need to collaborate. Police departments generally don't like to share. We think we can do it all ourselves. The question I would pose is why collaborate against trafficking? I think the bottom sure is why. We all work together. It'll minimize, at least minimize. It'll never end it, but it'll minimize how many people fall through the cracks. And I think my experience has been these multidisciplinary teams, these MDTs. I think both Jen and Charisma had mentioned these MDTs. And I mean, it speaks for itself. Child welfare. Everybody has to be at the table. Child welfare agencies, healthcare, victim advocates, social service providers, prosecutors. Everybody has to be at the table. And then some of the things I've noticed in being involved in these is that some of the characteristics, it can't be solely, like it says, executives, directors, supervisors. It has to be the people who are going to be at the ground level, on the streets, if you will, the boots on the ground. And the reason is they have to trust each other. If the supervisor, this is solely from the top down. It could be just become like another directive of just top down. Do it for the sake of doing it. When you have the people who are actually going to do the work, interacting with each other frequently, a trust develops. And for me, personally, what I recognized was I didn't have to worry about when we brought a victim to Hasbro Child's Hospital, for instance. I didn't have to worry about who I would see there, or would they understand what I was asking them to do. That was a built-in understanding, and that understanding was based on trust and meetings with people and getting to know people, and I think that's important. It's easy to say, we all do our own job, but you have to trust that the other people are doing it. Hospitals and advocate groups, prosecutors knew that these were difficult cases, difficult witnesses by the very nature. So that trust is so important, I think, to have a successful collaboration. And the the other thing too is this development of a standardized protocol, if you will, and that protocol is important. I'm not a big policy guy, but you have to have that protocol, and that protocol does exactly that. It minimizes people falling through the cracks. It closes the cracks, if you will. And I think that the way this is important work, the stakes are super high. We're talking about the well-being of young kids. It's too high not to do it the best way, and I really believe that my experience has told me that these multidisciplinary teams is clearly the way to go. The success, I believe, of an MDT, and this is solely my experience. You have to share information, and you got to share it promptly. You got to continually share it, and it's got to be coordinated so all the right people are getting the information. And some of the things I've noticed is that privacy issues, that the health privacy issues, they can become a roadblock if you want. They'll only become a roadblock if you let them. In the state of Rhode Island, there's statutory issues with our state child advocates, our welfare advocates, and we haven't allowed it to be an issue. And the way it was addressed was, we know it's an issue, and how can we help? How can we help the state agency overcome or change law, if you will? So I think that information sharing is an absolute must, and anything that impedes that sharing of necessary information, clearly some stuff doesn't necessarily have to be shared. Anything that you can do to help those choke points, you need to do it collaboratively. And if we move to the last slide, and I'll briefly wrap up. These are issues when collaborating with multidisciplinary teams, law enforcement advocacy. I saw this early on, and I say that the devil's in the details. We seem to be at a point where we were trying to perfect the protocol. Needed to be perfected, and I throw in there, and maybe it sounds a little irresponsible, but I use the term ready, shoot, aim, meaning we needed to get moving. And every day we wasted waiting for the protocol to be perfect, there'd be another victim that we would miss. And so I just think, when you get it close, get working, and help as many victims as you can. And it can be a dynamic process, that perfecting the protocol. But I still think you can't wait for perfection. It's just the stakes are too high, and it was touched on with our other two speakers, runaways. They're going to run. My experience is they're going to run. Don't be surprised, and have a plan. And in the state of Rhode Island, I'm happy to say that there's HSI, Homeland Security Investigations, is the federal agency. They've really taken the lead. We have a federal, state, local law enforcement task force, kind of built as an offshoot from the MDT, and it's very common to see a blast email in the law enforcement community saying, looking for a runaway believed to be in trafficking, and plenty of responses and sharing of information across jurisdictions, and I'm happy to say that it has really resulted in more often than not some really quick recoveries and some good results. So that wraps up my portion. I hope it was helpful. Again, as a pretty traditional policeman, my eyes have been opened. There's a better way to do my job, and I'm very glad that I've had that happen. And it has to do all with the partnerships with, again, family services and other child advocates and other child welfare people. So again, that wraps up my portion of the presentation.
Great. Thanks, Mike, Jen, and Charisma. We're going to move into the question and answer section of today's webinar, and wanted to just give you guys a minute to catch your breath and think about the amazing questions that we're receiving so far from all of our participants. So I'm going to give you all this first question, and would love for all of you to answer if you have something to contribute to the conversation. One of the first questions we have is, what are some of the steps and you all have mentioned some of these, that your organization has taken to make the shift toward becoming a more trauma-informed agency, specifically with this particular population. Where have you been and where are you going? And I know, Mike, you talked quite about this in terms of the law enforcement culture, and I'd love to hear from everyone as well in answering this question.
I could jump in quick. I mean, I think for law enforcement, it just makes sense. There's no way, it's impossible to expect a victim, a traumatized victim in these cases, to cooperate with the police without them being, their health and safety being foremost, being patient with them. So worrying about their safety first and then cultivating this trust. I think it's impossible to do it any other way. And I think if you explain it, and maybe from my point of view, if I explain it to other police departments or policemen and use real life examples, I think after a while it does sink in.
And Mike, just to follow up on that really quickly, we've received several comments, and everybody wants you to come to their organization and work with their local police department in helping them make this shift. Do you have any recommendations on resource materials that you all have used to start that approach, within your own organization? I know you worked with Family Services of Rhode Island. Do you have other materials that you'd recommend that these folks can use as they're having these conversations with local law enforcement?
I'd have to dig some up. I mean, I don't have any real handy resources right now.
Okay.
I have a quick PowerPoint. I really like kind of a case review, and I think that's been fairly well received when I've spoke to other law enforcement departments. I think it's just to kind of take it slow. And I think maybe the approach to family services, maybe they had the plan all along that they would change the culture. I don't know. But I think maybe if you kind of you're not really trying to force it down their throat, but who's going to argue with something, a protocol, a plan, a partnership that's going to help young victims? You're right, they can't argue with that. And I think most police departments are really heading in a progressive direction. So, I think if you take it slow like that, it could help.
And I know for,
oh, sorry.
Go ahead, Chrisma.
Oh, I'm sorry. No, go ahead, Jennifer.
Well, I was just going to say, Mike and I have been fortunate enough to work together throughout the years because I served on one of our GO team, which is a portion of the police liaison piece that I talked about in my portion of the presentation. And I think one of the things that both the department and family service have talked about throughout the duration of our relationship is that the intention was to assist each other where we knew the limitations of our role ended. And the unintended outcome of what really happened was that we learned from each other on both ends far more than we ever thought would happen. And so a lot of it was really pacing and taking our time and understanding roles and respecting roles, but also, one of the things that we often know is that if we say we're going to be there and we're going to respond in the time period we're going to respond, we will be there. And that's part of what's worked is you have to ensure that whether it's the community-based agency or whether it's the department, is that what you say you're going to do is what you do. And that matters tremendously to police officers because they are so limited up until a certain point on their role as legal personnel. And then we have to kick in, but we have to kick in right at that moment that they need us and not a second later because that reliability and dependability is important. And if anybody would like more information on kind of the community services end about how to build that relationship, folks can contact me. I can pass on information for our Vice President, Dr. Susan Ursling, who is the creator of that relationship as far as building the framework and the foundation. So we can pass that on to anyone who might be interested.
Great, thanks, Jen. And Charisma, what would you like to add?
Yes, so in addition to establishing protocols and delineating roles and responsibilities, like I said, in 2009, even way before Senate Bill 855 had passed, we in San Diego, we truly do have a culture of collaboration. And so the key was for us here was trainings in the communities about awareness and identification to to lay a foundation of culture change, and to really understand childhood trauma, the trauma of CSEC, et cetera, and highlighting that this is not a victimless crime. And so with those trainings also came cross-system trainings. And so even in our trainings, presentation for trainings, we have a multidisciplinary approach where someone from law enforcement comes and talks about their piece, child welfare is there, education, educators are there, a community-based provider, a service provider. And so the audience can see right from, what we're talking about. We have all been working together. This is possible. And another point is really buy-in from key stakeholders, that, not only from, the top to bottom, but really, and the bottom up, right? It's a reciprocal process. And so our work really started through what we've always done as agencies and providers is information sharing, like Mike had stated, that we really had a shared goal for better outcomes for our children, and really established a collective ownership, and also evaluated, what needs to be improved, right? That constant tweaking, but still being respectful, of our disciplines, our perspectives, and our practices.
This is Jen Hostler. I want to jump in real quick too. And Charisma, you took the words right out of my mouth. I was going to mention, our project here at Chadwick. While it's not focused specifically on working with CSEC youth, it is focused on creating more trauma-informed child welfare systems, which certainly includes this population. And one of the things that we've done in the communities we've worked with is training, and it is really to create a general awareness about trauma, as Charisma mentioned. And I just want to mention two of the curriculums that we've actually trained in our communities. We're working in Rhode Island, as I mentioned. We're working in Florida, Oklahoma, Minnesota, and California. So we provided training to child welfare staff. There's a NCTSN curriculum called the Child Welfare Trauma Training Toolkit, otherwise known as the CWTTT. That is it's designed to be sort of a trauma 101 for child welfare workers. It helps educate them about how trauma actually impacts the brain, how it impacts development. So there's some real basic education in there that I think is really valuable and relevant. And then it also talks about the essential elements of a trauma-informed system. And what we found was when we did these trainings in these communities, we encouraged people to invite and include other partners, so not just for child welfare. So while this curriculum is sort of initially designed for child welfare, it can easily be adapted for many systems. And what we found was, for example, in Rhode Island, we had child welfare, we had mental health partners, we had juvenile justice partners, we had, a few other, we had some, former youth in the room, and what we found was getting all of those people together helped create a little more empathy for each other and for our roles. So it helped sort of, like Charisma said, it helped solidify the idea and the point that we've all been working on this, but we've just been doing it in our own silos, and we really need to kind of knock some of those silos down. So I think the training piece, while it's not everything, I think it's a very great start. And the other curriculum I want to mention is the resource parent curriculum. That's more geared towards caregivers, but again, there's a lot of content in there that can be adapted and shared with other systems. So I think training would definitely be a great start. And then just lastly, I'll mention the creation of sort of cross-system teams. So, for example, in Oklahoma, they've got a trauma team that's been meeting for 3 years, and it's a group of people from the community. So it's law enforcement, it's juvenile justice, it's child welfare, it's Department of Health. It's all of those people that get together and meet, once a month to talk about some of these kinds of things. And so that's how they've been able to make progress and move some of these things forward in their community. So that's my
Thank you so much. Our next question is very different in terms of asking how you all address managing serious behavior problems among CSEC youth when these repeatedly threaten their foster care placements, how you work with foster parents, implement effective trauma-informed parenting, etc. Can you all speak to that a little bit?
Sure, I can speak to that. And so, again, the common theme today is going to really be about training and the training of our group home staff, of our foster parents, letting them know that this is what CSEC looks like, this is what the trauma of CSEC looks like. And so, the behaviors that you are seeing are certainly, the symptoms of what has happened to them up until this time in their life, which also includes, of course, the complex trauma early on in childhood. And so strategizing constant support for the foster parents and even schools to know that, because, we've also trained school personnel, as we have about 42 school districts here in San Diego County alone. And we're currently working with San Diego Unified on training them about what CSEC is, warning signs, risk factors, et cetera, and knowing, when to report. But again, I think it's really about identifying behaviors, knowing where they're coming from, inquiring, asking for support. Because if we need to put more intensive in-home services in there, or even looking at non-traditional treatment modalities, we want to be able to have this be a safe and successful home, not for just that youth, but if there's other youth in the home, for the foster families and the communities that they live in. But constant training and feedback and support.
Well, and I can jump in on my end too. This is Jenny too in Rhode Island. I think that Jen Hostler mentioned a lot of really important training tools, especially sort of the resource parenting guide. I think it's important to always remind foster families and residential staff, because vicarious trauma and secondary trauma are very present when working with CSEC youth and traumatized youth in general. And so self-care is really essential. Psychoeducation and really being aware of what those trauma-reactive behaviors look like, how they might impact you as a foster parent or a provider for CSEC youth. I think it's really important to always remind yourself that it really isn't about you. It's about rebuilding that relationship with a youth who has been really traumatized and has really lost a lot of their ability to trust themselves, to trust the people closest to them, and to trust the world at large. And that it's really not about us as caretakers. It's really about rebuilding that trust and that relationship, because treatment can't happen without it. But trust and that relationship building has also been really tore down by somebody who has trafficked them or pimped them out, because they've sort of rebuilt this really ugly version of what it's like to care for somebody to get them to be trafficked. So you have to undo that, and in undoing that, a lot of those trauma-reactive behaviors as it relates to their ability to trust is really going to be, re-triggered and re-traumatized, and to be as grounded as possible is really essential. I think, for those of you who might need some additional resources, the NCTSM Learning Center has a tremendous amount of information about how to work with traumatized youth, and whether it's a CSEC youth or a youth who's been impacted by abuse or neglect, those symptoms are all very similar. And so to have, knowledge is power when working with any of these youth. So the more that you know and the more you can support them from a really rational, clear place when those reactive behaviors come up, the better you're going to be able to help them move forward.
Any other thoughts or comments about this question?
I think from the law enforcement, I don't know that we have a tremendous amount of influence on this issue, but I know from my experience from the beginning, explaining that you were going to introduce some services to the victim. I think it builds that relationship. I think my experience is telling what a wonderful opportunity this is. It may seem like the worst day of your life, in the sense that you're in the mix of this, but what a wonderful opportunity that awaits you. So I don't know if that sets the table, but I think that approach has been helpful for us.
Thanks so much. And Mike, specifically this next question is for you, and as always, I welcome the others to give their perspectives. It's an interesting question. Shifting the culture away from the criminal model to more of the victim model that you talked about. So when you're looking at CSEC use, where does substance abuse and dependence fit within that model? Is that part of the victimization, or is substance abuse viewed still from the criminal standpoint, or are you looking at the individual as a whole?
I think we look at the individual as a whole. I think that one of the things that law enforcement possesses is a great amount of discretion, and I think that we've turned the corner. We've turned the corner. Law enforcement, I'm pretty safe in saying, turned the corner in that it's a victim crime. The people who are involved in this behavior are victims. Seeing less and less arrests, charging young kids in particular with prostitution, and as far as if they're abusing alcohol or drugs, I don't think that any policeman's worrying about that. We look at that more of that's a way to facilitate this whole crime. It's clear that pimps are using alcohol and using drugs to groom these victims. So I don't think that, from our point, or at least my point of view, we're not looking at alcohol or drug substance abuse as in a criminal way. More of a criminal way that the pimp is using it to develop or to get this behavior